today's episode. Our guest today is Dr. Jason Zelt, a MD PhD candidate with the University of Ottawa's Faculty of Medicine. His research is focused in understanding the mechanisms of right heart failure in pulmonary hypertension to ultimately develop treatment strategies for patients. Dr. Zelt's research embraces scientific discovery in a true translational fashion by incorporating both in-lab benchwork and interaction at the patient bedside. Even at such an early stage in his career, his productivity in the field is truly remarkable. Dr. Zelt has published 22 peer-reviewed papers, 14 of which are first author. In his PhD alone, he has published 14 articles with an additional 5 that are in the review process. And aside from his research, Dr. Zelt has held several leadership roles in the academic and trainee community. And some of these include serving as an editor for the University of Ottawa Journal of Medicine, founding the Ottawa Medical School Application Seminar Series, and holding a position on the MD-PhD Interview Committee. He is also currently mentoring 2 junior medical students on their research projects. Recently, Dr. Zelt has been awarded the Ottawa Region Cardiovascular Research Trainee of the Year. So congratulations, Dr. Zelt, and thank you so much for being here with us on BEaTS Research Radio.
Thanks for having me, and thanks for the introduction.
So as I mentioned, your productivity at this stage in your career is truly impressive. What would you say your biggest motivator and motto is for your research?
Interesting question. So I think it would be easier, although somewhat simplistic, to divide this into really intrinsic and extrinsic factors. I think if I just begin with the intrinsic factors, I think like most people interested in science, it does take a special person. And I think I share this among many researchers, like an innate curiosity for understanding complex biological processes. As well, I was actually super fortunate, as you said. So I'm in the MD PhD program at the University of Ottawa. So being a part of the MD side, I was actually very fortunate to go into clinics with my supervisors, one of which was Dr. Milanchuk, who is a world expert in pulmonary hypertension. And being able to see kind of firsthand how this disease impacts people's day-to-day function and quality of life was definitely an important motivator for me to pursue this line of work and work so hard to try and really further understand and hopefully one day develop therapeutics for this patient population. I think a lot of people ignore extrinsic factors, although somewhat individualistic. I think they can also be very motivating. In the MD PhD program, we're only allotted 3 years, 3.5 because we have some summers. So we have a little bit of a shortened time period, but again, they fully expect us to complete a full PhD. So kind of having that stress always looming over me was definitely a powerful motivating factor. And I was also very fortunate to work with some world leaders in pulmonary hypertension and in molecular imaging. And I think working with these people who you grow to respect their research and their research curiosity and integrity, I think they can also serve as very powerful motivators to keep you on track and really, really push forward when you need a little bit of a boost, for sure.
Right, definitely. It sounds like you have a lot of good mentors in your lab environment. So that's great. During those 3 years, you published 14 papers. So which one would you say? Do you have a favorite one of those, and why was it your favorite?
Yeah,
if you do have one.
I'm gonna bend your question a little bit, but probably. I've kind of dabbled in a few different fields. I would say something that I'm particularly excited about is a paper we're trying to actually finish right now. And so, as I mentioned, so we study pulmonary arterial hypertension and right heart failure. So just so that the audience knows, kind of give a little bit of context about the disease. So pulmonary arterial hypertension, it is a rare disease of the pulmonary vasculature. And just like systemic hypertension means high blood pressure, pulmonary arterial hypertension is high blood pressure within the vasculature in your lungs. Now, we all know our systemic vasculature, which provides blood flow to the rest of our bodies, and the left ventricle is the pump for that system. In contrast, the right ventricle is the pump for the pulmonary circuit, which goes to the lungs for oxygenation. And the left ventricle and the right ventricle are very, very different in terms of their embryology, in terms of their shape, morphology, and function. And the right ventricle is actually used to seeing a very low pressure, so it is a thin-walled chamber. And what happens was when you increase pressures in the lungs, because the right ventricle isn't used to seeing such high pressures, eventually the right ventricle fails, and that is the leading cause of death in these patients. So we study right heart failure kind of induced by pulmonary hypertension. And so at the beginning of this work, we were collaborating with a scientist at the TOH, Dr. Duncan Stewart, and he came across a really interesting finding in a rat model of pulmonary arterial hypertension. And what he found, he was looking at the same disease model in two different strains of rats. One rat strain is called Fisher rats, and the other is called Sprague-Dawley rats. And Fisher rats are an inbred strain of rat. And what's actually interesting is that despite the same model and independent of the degree of hypertension, so both rat strains develop the same degree of hypertension, the Fisher rats have a propensity for right heart failure and all die by about 5 weeks, whereas the Sprague-Dawley rats have excellent survival out past 8-9 weeks in this model. So it seems that the Fisher rats have kind of a genetic susceptibility to progression of right heart failure, and this was termed maladaptive right heart failure. And what's interesting is that these two animal models actually nicely recapitulate what we see in humans, and that in humans there's marked heterogeneity in the prognosis, and that some patients, independent of the degree of pulmonary hypertension, some have a much more favorable prognosis, whereas others unfortunately succumb to their disease very early within a few years. So this gave us a really good model to really explore genetic differences. And when we explored the genetic differences between these two strains within the right ventricle, one gene actually really popped out to us. There was only 6 actually that were differentially expressed and in common, both in terms of healthy controls and the disease animals. And it actually related to energy metabolism. And this was a gene called AK1, which is an adenylate kinase. And what it does is, we all know that the mitochondria produces energy. So what this enzyme does, it forms a chain reaction and helps transport the high energy phosphates and ATP from the site of production to the ATP, the actin-myosin complex for muscle contraction. So the Fisher rats had a profound deficiency in this enzyme, which resulted in a severe energy inefficiency and leads to a propensity for maladaptive remodeling. So that's something that we're exploring and particularly excited about right now, and we're actually just working on the recovery model. So we think that we may have uncovered an interesting novel pathway in the development of right heart failure.
Wow, that's very interesting. So coming back to how it all started, the 2 strains of mice, was that kind of found, were they looking for it, or was it kind of stumbled upon as something that you didn't think there should be a difference and there was?
Yeah, this was work done by Dr. Stewart's lab before me, that they had found this. I came on after because I really wanted to understand why that was. To my knowledge, they kind of stumbled upon it. They were testing out the model in several different species, some of which developed this adaptive phenotype, whereas the Fisher seemed to be really interesting and have this marked susceptibility. And this is actually, Dr. Milnichuk and I, we tried this independently at the Heart Institute, and we actually found very, very similar results, and has also been recapitulated by other labs. So it seems to be a quite robust finding, and the dichotomy between the 2 phenotypes is quite stark.
Oh, wow. That's very interesting. And your model, so this is a paper that's in the process right now, and it's a mouse model as well?
So what's interesting about the disease actually is, so we've tried to actually generate pulmonary arterial hypertension in mice, but we think that in mice, their endothelium is able to regenerate. So you actually get quite robust lung regeneration in mice. So mice actually don't generate pulmonary arterial hypertension. So we actually have to do it in rats. So a lot of this work and a lot of the work in the field is actually done in rats. Yeah.
In rats. Okay, that's very interesting. I didn't know that.
Yeah.
So on to maybe more of the science of something that you've demonstrated and have published on. Some of your work has demonstrated that kidney function is important as an important prognostic marker in patients with pulmonary arterial hypertension. So what does that finding mean, and why is it important for patients in the clinic?
No, yeah, that's an excellent finding. So we were interested in the topic initially. This was kind of anecdotally in clinic. We noticed that patients who have marked kidney function have a poor prognosis. So it was something that we wanted to validate. And so, as I said before, so pulmonary arterial hypertension is a rare disease. It affects about 2 to 3 cases per million. So its incidence is quite rare, but we're actually lucky at the Heart Institute because it has such a large catchment area. I was able to put together a database of about 200 patients with pulmonary arterial hypertension. And actually, to my knowledge, I'm pretty sure this was the first cohort of pulmonary arterial hypertension in Canada. So it was interesting at looking at the landscape of this disease in a truly Canadian population. And so what we were interested in doing was first to look at risk factors for prognosis. And there are a few different risk scores that are available in the field, like the European Society of Cardiology has a risk score, and the US, it's called the REVEAL, based off their own database, have a risk score. So we were initially interested in comparing these different risk scores in the population to see which one was most robust in a Canadian population. And what we actually found was that the American REVEAL score performed better in a Canadian population than the Europeans. Now, something that was interesting about the European guidelines is that they don't actually include measures of kidney function. And we know that kidney function is an important prognosticator across many cardiovascular disease states. So we're actually surprised that it actually wasn't captured in the European risk score. And when we actually applied, just stratified based off your CKD staging, provided excellent discrimination between the CKD stages in terms of long-term prognosis. We had follow-up up to 10, 15 years. So it was really interesting to see.
Okay, that's very interesting. So it wasn't, it just was not included before. And it seems surprising the way that you're talking to me about it now. It seems like it's something that shouldn't have been missed.
Yeah, it's a rare disease population. I think it's become increasingly aware that it is an important prognosticator. For example, like the American REVEAL score included a marker of kidney function, but it wasn't actually quantitative based off of an EGFR. It was a physician's assessment whether they had kidney dysfunction or not. So we went back and we actually used EGFR cutoffs on a quantitative scale to ascertain how important this prognosticator was. And actually, we developed our own risk model. We captured many different variables, and we used a computer algorithm to really select the variables that had the most prognostic information in a Canadian population, and EGFR came out. So we do believe that it is a very significant and important prognosticator in a specific patient population.
Right. So is that what you were saying, that you developed a risk score? Are you speaking of the Ottawa risk score that you had developed for pulmonary arterial hypertension?
Yeah, so that is something that we derived from our current database of about 200 patients. So I had mentioned these two kind of risk scores that have become popularized in the literature, the Europeans in comparison to the Americans. And if you survey random clinicians who specialize in pulmonary hypertension, the compliance and use of these risk scores is actually quite poor. If you look at them, their perceived complexity is actually quite extensive. They incorporate 14 to 16 variables. And for a busy clinician, that makes it extremely difficult to use. So when we derived our risk score, we really wanted to only incorporate variables that statistically had the most robust and most prognostic information. And so we tried to simplify it down to really increase its utilization within the pulmonary hypertension community. So we derived 4 variables that we determined had the greatest prognostic significance. And these were a patient's sex, their 6-minute walk distance, so their exercise capacity, their eGFR, so kidney function, like we have just previously discussed, and their mixed venous oxygen saturation. So those 4 variables we think provide very good discrimination. And what's interesting is that when in the derivation cohort, when compared to the reveal, it provides almost equivalent risk stratification compared to a risk score that incorporates up to 14 to 16 variables. So we think that we've really simplified it. And clinically, we think that this is important. So in the 2015 European guidelines, was the first time that really risk assessments started to be incorporated into guidelines. So it's actually really difficult to predict the prognosis of a patient with pulmonary hypertension. And it's actually been shown that a physician's clinical gestalt is not as good as a formal risk assessment. Because it is so difficult to predict a patient's prognosis, the guidelines actually recommend a multi-parametric risk assessment. So that's what we're really trying to improve upon to increase compliance. And the next step of this, after we derive the risk score, we've actually just formed a collaboration with a group out in Calgary with Dr. Jason Weatherall. And so he has a small cohort of patients with pulmonary arterial hypertension as well. So we're in works right now validating the model, but it looks like it does perform in a validation cohort very, very good as well. So once we complete that, the next step is to really implement it in clinical practice and really show that using this simplified risk tool can improve patient outcomes. So that's the next step. And so I don't know how are the listeners or people are familiar around the treatment, but the treatments for this patient population are actually very, very expensive. And so the way that the ministry kind of earmarks these drug treatments is based off of a patient's risk factors at diagnosis. If a patient is considered a high risk, they're going to be put on more advanced therapies than a patient who may be considered something like intermediate or low risk.
Okay.
So that's where we're going right now into the future.
Right. And so this is a tool that will be used by clinicians for patients after diagnosis, correct?
Exactly. Correct.
That's very interesting. It's been described also as having practice-changing potential, which is incredible to kind of create something that's going to be implemented and will better people's lives. Is very, very amazing. So congratulations on that project and your collaborators as well.
Thanks. Yeah, we're really excited about it.
Yeah. And just a final question here to, I guess, give a broader view on all of your research. What kind of brought you into the cardiopulmonary research field, and what sparked your interest, your initial interest in it?
Yeah. So I think initially it was working with Dr. Milanchuk, and I've had such an amazing team that was kind of gifted to me when I first started doing this research. I was able to go into the clinic, as I said, with Dr. Milanchuk and really see kind of firsthand how debilitating this disease is and how much of an impact it has on a patient's functional outcomes. So I think that was really important for me to go into the field. I mean, there was also an important intellectual component. So if we look at the etiology of the disease, so most patients are actually characterized as idiopathic. So we actually don't know what's causing the disease. So I think intellectually that's, for me, an interesting field to go into because there's a lot of space for discovery and innovation. And in terms of right heart failure, while we have many treatment strategies for left-sided heart failure with reduced ejection fraction, we actually have no approved therapies that directly nor selectively target the right ventricle. So from that perspective as well, I think there's a ton of room for innovation and research moving forward. So I think that initially kind of drew me to the area.
Right. Yeah, we'll definitely be watching your publications and seeing more come out, I'm sure, which I'm sure will benefit lots of patients in a couple years' time, and maybe even this year. So thank you so much for joining us here on BEaTS Research Radio and talking to us about your incredible research field of cardiopulmonary research.
Thanks for having me. I really appreciate it.
No problem. And thank you also to our contributors, the University of Ottawa Heart Institute, the BEaTS Research Lab, and the Department of Biochemistry, Microbiology, and Immunology in the Faculty of Medicine at the University of Ottawa.